At the European Society of Cardiology this year, we're presenting some really important information that will be helpful to people to improve the care of patients with atrial fibrillation. And much of what we're presenting at this meeting has to do with optimizing anticoagulation to more effectively prevent stroke for patients with atrial fibrillation. This European meeting this year in Rome is now the largest cardiovascular meeting in the world. And there are something like 30,000 cardiologists here from all around the world sharing information about research updates, about best practices to improve care of patients with cardiovascular disease. And so this is a very important meeting. Part of that meeting involves some of the research that we're doing from Duke University and with our international colleagues, including in understanding how to best prevent stroke for patients with atrial fibrillation. And it was at this meeting 5 years ago that we presented for the first time the results of one of the large trials, a trial called Aristotle, which tested one of the new blood thinning drugs, one of the new anticoagulants for patients with atrial fibrillation to prevent stroke. And 5 years ago what we presented was that this drug, apixaban, was better than warfarin at preventing stroke, resulted in less bleeding, and resulted in lower mortality. And since then we've been doing lots of different analyses to better understand how do we best use this drug in clinical practice. The Aristotle trial included 18,000 patients from around the world with atrial fibrillation and at least one risk factor for stroke, who therefore had a need to be on an anticoagulant. And with a trial of this size, it included a wide variety of patients, including elderly. We had a patient who was almost 100 years old, including all different racial representation, including large numbers of women, large numbers of patients with renal impairment, large numbers of patients with prior stroke. And then one of the areas that we thought was an important one is we included patients who had a history of falling. So it turns out that of all patients with atrial fibrillation, only about half are treated with an anticoagulant. One of the reasons that half patients are not treated is because of concerns over falling and frailty. And it turns out that there was a study now several years ago published in the Archives of Internal Medicine, which was a decision analysis study, which suggested that one would have to fall 295 times a year to overcome the benefits of anticoagulants in preventing stroke. So we believe that this issue of not treating patients because they have had falls is a really important one, because there are lots of patients who should be treated who are not being treated now because of falls. So what our study showed, we looked in the Aristotle trial, and about 5% of patients had a history of falling in the last year. And not surprisingly, those patients were older, they had more comorbidities, they had a greater chance of having had fractures. And then when we looked and saw how did they do on either warfarin or apixaban, they did have much higher risk of stroke, of death, and of bleeding than patients who didn't have falls. But it was not so much higher that we would expect that the benefits would still not outweigh the risks. In other words, it still appears that being on an anticoagulant for these patients was something which was very important to prevent stroke, and it outweighed the risk that these patients had. But also importantly, one of the benefits of apixaban over warfarin is it has less bleeding. It has about 1/3 less bleeding than warfarin overall. But it's never been reported in this particular population until this meeting. And what we saw is in this population that seemed to be especially important. For example, even though they're small numbers, there were, with respect to subdural hematoma, perhaps the biggest concern about anticoagulating a person who has falls. 5 patients in the warfarin group had a subdural hematoma and 0 in the apixaban group. So it appears that apixaban is likely a very attractive choice for patients who've had a history of fall and are at higher risk for bleeding, including intracranial bleeding related to falling. This data really is very consistent with much of the other data that we presented, that apixaban has these major advantages over warfarin in less bleeding, in less total bleeding, in less major bleeding, in less intracranial bleeding, and now the new findings, less intracranial and other bleeding in this very high-risk population. We've shown this before in the elderly, we've shown it for patients who have renal impairment. These are some of the other high-risk groups. And now in patients who have falling. It's also important to point out that similar findings have been reported with the other NOAC drugs, the other new or non-vitamin K oral anticoagulants. All seem to have this feature of less hemorrhagic stroke and less intracranial hemorrhage than warfarin.